For the cervicogenic headache, you have to be up in a above C3. C3, 2, 3. The lesser occipital is C2 and 3. Greater is C2. And you can spread safely up in that area. Flexion rotation will help you to have the runoff. Now, for the suboccipital decompression, what we are talking about is the greater occipital nerve coming out at the base of the superior pars. So we go a finger breadth off midline and feel the nuchal line where the muscles are inserted, and then you aim down towards the superior pars. You feel a pop, pop as you go through the muscles, and you stop at the level of the spinous process. You have to be through the long muscles in the neck, in this compartment that includes the greater occipital. You can spread to the lesser occipital, the C2 portion, and injecting the contrast should not be done with a sharp needle, because you can inject into the nerve or into an artery. It is only possible if you inject with a sharp needle to inject into the wrong spot. Now, the stealth needle, which has the curve and it's sort of blunt, you can aspirate, make sure you're not in a vessel. That means vein. If you are in the artery, it will pulsatile spread back. And you stop in the right spot. Now, if you just inject the nerves on the surface of the skull, it's like peeing against Niagara Falls. You're not going to turn the falls. It's just works for 2 weeks in a study mood. Doing injection into the suboccipital compartment works for 24 weeks. Remember, Botox, which costs by the time you put it in $2,000, works for 11 to 12 weeks. And this in a study mode, 2 studies, one from Brazil and one from Texas Tech, Ralph Justice and myself. We found exactly the same outcome, 24 weeks in a study mode and a couple of weeks when you just inject it. It's overwhelmingly obvious. There's a great paper in combination with Andrea Truscott that recently has been published that will be listed in the references. So these are some of the safety concerns that please keep in mind, because you will help your patients. And by the way, a study is not a clinical experience. I injected my own mother in the sitting room, and she got 13 years pain relief from bilateral suboccipital injection. It was in the days when I didn't know about sharp needles. And looking back, I'm just ever so grateful that it is not a very frequent occurrence, but you can have a locked-in phenomenon from intraneural injection. And there's respiratory arrest and cardiac arrest in a setting where you maybe not ready. So it's better to do it safe, and this has been one of the safest and best procedures in my hand. Exception in the operated patients, you have to be very careful that you don't get subdural or subarachnoid. And so far, we haven't had a single disaster. I've been an expert witness in trying to help doctors because doctors deserve help.